actually the most primitive and widespread human experience. So you define it as an would have with illicit pain as a defense mechanism to protect us from injury stimuli. And chronic pain is inherently distressing, particularly those who suffer with chronic rheumatic diseases. And this is the primary reason that they see a doctor. Now, patients suffering from congenital insensitivity are predisposed to self-mutilation. So, I highlighted this because some individuals, particularly those with genetic defects, they wouldn't really have any degree of pain sensation. So, you would notice several individuals that does self-mutilation, they would hurt themselves, so you have varying degrees of pain, and these are what you would describe as the outliers. And notably, it's very important to emphasize that pain is not equal to suffering. You would be surprised that some would really want to feel pain, no? Yung mga tinatawag nating sadomasochist. So these are real individuals. So again, emotion is part of the definition of pain. Now, for this table, I just have to highlight that when you talk of acute and chronic pain, now you can more or less define chronic pain as chronic non-malignant or non-cancer pain and as well as chronic malignant pain. And it's important to highlight this because the pharmacologic options, when we talk of chronic cancer and non-cancer pain, are multimodal. As compared to acute pain, you would really need analgesics, and most instances you would also need anti-inflammatory for particular rheumatic diseases. And when we categorize pain, we're all familiar with nociceptive pain, neuropathic pain, and I'll just focus more on the nociplastic pain. When you say nociplastic pain, so nociceptive pain, we're all familiar with this. There's a tissue injury. You have the somatic nociceptive pain and the visceral nociceptive pain. When you talk of neuropathic pain, you have the small fibers, the nerve endings that goes into the central pain sensitization pathway. Now, when we talk of nociplastic pain, it's just a recent category, and it was introduced in 2016. It's a mechanistic descriptor for chronic pain states that cannot be clearly or vaguely characterized by the activation of both your nociceptor and the neuropathic pathway. So they would exhibit, aside from the clinical manifestation, they would have psychophysical presentation that would suggest an altered nociceptive function. Unfortunately, for the female sex, usually you would find them among the female sex. And many of the rheumatic diseases has predominantly a female sex preponderance. So again, your nociplastic pain is chronic widespread pain, chronic primary musculoskeletal pain, chronic primary visceral pain, chronic primary headache pain, and complex regional pain syndrome that we're all familiar as rheumatologists. So we go back to this often used reference for the pain pathways. You're all familiar with this. I just have to highlight that when you talk of pain, the sensitization goes up to the central pathways, and you have different pharmacologic targets. So you're familiar with the NSAIDs, the analgesics, you have central blockers. So there's a lot of multimodal approach in trying to address pain sensitization. And it's also important to highlight the sexual dimorphism of pain. As we mentioned when we define nociplastic pain, you would have differences both in the hormone of a female and a male sex, brain neurotransmitters, as well as the immune systems. There are several immune cells and cytokines that play a significant role depending on the sex that you carry. Now, just briefly, currently, when we approach pain, we're into this traditional model. We have the non-opioid drugs. The Philippines is proud that we didn't really encounter an opioid epidemic we see in the developed countries. We don't really utilize much of these opioid drugs. So we have a lot of experience with regards to traditional NSAIDs, the non-opioids, and then we have opioids, which is also quite controversial at this point. And the Philippines is quite strict with that. And you have the non-pharmacological, the psychological, and the exercise and behavioral therapies. You also have the rejuvenating non-pharmacologic approaches. You have acupuncture, central sensitization pathways like neuromodulations, and even microbiome. So there have been spreading out data with regards to the role of your gut to your pain sensation. And then you have this emerging or novel therapeutics. You have gene therapy, they're looking into that. You also have monoclonal antibodies, as I will show in the next slide, and stem cell therapy. So there are a lot of molecules actually in the pipeline that looks into targeting specific pain pathways, and they're looking into the role of even monoclonals, particularly on specific disease states. For example, trigeminal neuralgia, patients with spinal cord injury, peripheral nerve injury, bone cancer pain, and even migraine. So these are on the horizon with regards to approaching pain. So we must be experts when we talk of pain. So as Dr. Dong mentioned last night, no, sabi niya, may mga nagtatanong, why do you need to take 2 years to learn about NSAIDs and steroids? No? So hindi na ganun ang field natin. There's a lot on the horizon that will become familiar and expert as the days to come. So, we go back to the traditional drugs that we use for pain, particularly for acute pain. We're all familiar in using NSAIDs, traditional and the COX selectives. So you further subdivide these traditional NSAIDs. You have the salicylates, the paracetamol, phenylacetic acid, oxycamps, pyrasolone, phenamates, and the COX selective NSAIDs. So we'll focus on these propionic acid derivatives, which is naproxen. So we now focus on the drug. And now, because of this molecule, they're highlighting the role or the benefit of fixed dose combination. You're all familiar with fixed dose combination with regards to pain control, and that is one of their products, the tramadol, paracetamol. Now, how different is this fixed dose combination to the current available analgesic that we have? So basically, the goal is to really provide an additive effect, if possible, a synergistic effect, and we want to prevent drug resistance among these patients, particularly those suffering from chronic pain states. So, you're familiar with the naproxen. I just have to highlight that when you couple naproxen with sodium, there's a more immediate effect. So usually the pain relief will begin half or 30 minutes than the usual 1 hour with the plain naproxen. So you want it to couple with the chemical structure with sodium. And we all know that among the traditional and the COX-2 selectives, the cardiovascular toxicity would be less for naproxen. So all of them will have cardiovascular warning. But when you talk of the cohorts that are available for naproxen, they say this is the lesser evil among all this when we talk of cardiovascular outcomes and toxicities. So you're also familiar with paracetamol. We know that this is a drug that has a weak anti-inflammatory and analgesic effect. So that's why we do mega doses of paracetamol to achieve analgesia. That's why we want to couple it with different drugs. But it has been a mainstay for the longest time in addressing pain as well. Unfortunately, even if it's been present for the longest time, we still don't know its exact specific mechanisms. So they are saying that there are some central pain pathways that your acetaminophen addresses. You have affectation of your serotonergic pathways. There is some opioid effect. So at the moment, it has been useful for so long. So we want to maximize its potential by coupling it with a different drug. So just going back to the central pain sensitization pathway, we know that in the pain pathway, you have the peripheral nervous system, and then you have the transduction, transmission, and modulation. So we want to address the site of inflammation and also the central pain pathway. So when we target multimodal pain sites, we would achieve better pain control. So the good thing about this local company, like our industry sponsor for this launch, is that they have their own R&D. Not all local companies have their own R&D. No? So we usually rely on data from multinational when they come up with a new molecule and a new pharmacologic agent. So For the next proceeding slides, I'll be relaying or conveying the R&D that they developed for this particular molecule, which is a combination of the naproxen at a dose of 275 and paracetamol. So I'll be presenting their R&D, preclinical, animal, and as well as human studies and real-world data. So they looked into the in vitro efficacy of naproxen plus paracetamol in looking into their effect on specific inflammatory and pain chemical mediators. So they were able to identify these particular biological markers, the INOS2, the COX2, as well as the prostaglandin and the TNF-alpha. So they were able to demonstrate, comparing with the higher dose of naproxen, the 550, as well as the current available naproxen 325, with the combination of paracetamol and the 275 dose. So we would expect some dose-ranging effects with regards to their inhibition of these inflammatory cytokines. So they're able to demonstrate that the 275 naproxen in combination with the 325 paracetamol has no statistically significant difference on the higher dose naproxen, which is the 550 milligram, in inhibiting the INOS2, the COX2, the PGE, and TNF-alpha. And if you add the naproxen to paracetamol, it also augments the prostaglandin inhibition, that showing that when you do it with just the paracetamol alone, 325, the prostaglandin inhibition with naproxen is better. How about the analgesic activity of naproxen and paracetamol combination? So they look into, these are animal study using sprawly dog mice, rats. So they look into this outcome, the acetic acid-induced writing reflex. So di pala sprawly dogs, Swiss Webster mice. So what they do is they would inject acetic acid intraperitoneally and they would measure these writing responses. And they were able to demonstrate that the acetic-induced writing assay for the Scalan-Forte compared to the higher dose, as well as the 325, showed no statistical difference in terms of the percent inhibition of your acetic acid-induced writing reflex. The addition also of the naproxen augmented the analgesic effects of paracetamol, showing the better activity if you add naproxen to just paracetamol alone. How about toxicity? So we all know that traditional NSAID will have toxicity in the GI tract, and they're able to look into its toxicity among these rats. So basically, they evaluate the GI injury potential of the naproxen paracetamol fixed dose. This is the one that they use, the Sprout Dolly rats, using the L name or the L-nitro-L-arginine methyl ester hydrochloride. And they're able to demonstrate that naproxen, the dose of 275 compared to the paracetamol 325, show no statistical difference with the negative control in terms of the GI toxicity. And there's better safety profile than the naproxen alone when they dissected these rats and they look into their intestines. So they look into the stomach, the jejunum, and the cecum of these Sprout Dolly rats. So this table summarizes the in vitro and in vivo efficacy and safety data of your naproxen combination with your paracetamol. So with this efficacy question, is there a difference of efficacy between the Scalan-Forte, the 275, and the higher dose 550? When we talk of the INOS inhibition assay, none, as well as the COX2 and the prostaglandin and cytokine across the board, including the induced writing assay. Now, with regards to your paracetamol, it does have inhibition of your prostaglandin, but none with the other cytokines. It does somehow help in the animal experiment on induced writing assay. Now, the question with regards to just paracetamol alone versus the Scalan-Forte. So your Scalan-Forte across the board will have superior responses in terms of these inflammatory markers compared to just the paracetamol alone. We all know that paracetamol has weak anti-inflammatory activity. And they look into the component that drives these results, these markers levels. So it's the naproxen for the COX2, the INOS, and it's the combination of naproxen and paracetamol for prostaglandin, the cytokine ELISA, as well as the induced writing assay. So the clinical implications would be for INOS, they would definitely expect an anti-inflammatory activity. Same goes for your COX-2 and prostaglandin, and aside from the anti-inflammatory activity, you have analgesic and antipyretic activity. So you can probably use this in disease states like fever, non-specific clinical manifestation. And then the cytokine ELISA, you would have immune modulation. And for this experiment on the intraperitoneal injection of acetic acid, it's analgesia. Now, with regard to safety, they're able to demonstrate only on the GI tract. And in the in vivo gastrointestinal toxicity would be safer if you use the naproxen paracetamol combination versus the higher dose naproxen. So these are the in vivo in vitro efficacy data. Now we move on to the actual clinical human studies. So this is a recent study that they done before the launch of your naproxen paracetamol combination. It's done at Philippine Orthopedic Center by several orthopedists, and basically the article is still on press, but they completed it for a total of 5 days. They used the combination naproxen and paracetamol given twice daily, only for 5 days, on specific disease states among patients with osteoarthritis, meaning specific different pain grades. So they use the outcome measure of VAS, and they're able to enroll more of female subjects versus the male. So the most common OA site would be the knees, and it would affect almost half the participants. And they would have corollary radiographic presentations, as well as clinical and physical validation of their osteoarthritis. So they look into the change in pain score at rest and with movement, and they're able to demonstrate that after the 5 days treatment of their naproxen and paracetamol, there would be improvement both in the pain score, there's significant reduction, and also during, not only at rest, but also during movement. So the median pain score would be decreased from 4 at baseline to 2 at follow-up, while the pain during movement, the score would decrease from 6 to 3. I think it impacts with regards to the clinical utility of this drug. Some patients would prevent being ambulatory, they would refrain from going out. So here, they're able to demonstrate that at rest and even upon movement, there will be benefit. There will be complete pain resolution at least a third of the patients at rest, and at 10.45% during movement. And the combination therapy, there is no safety signal. It was well tolerated with only 3 mild adverse events. How about on a larger data set? So, kanina, smaller lang yon sa POC. They look into OA patients. So now they look into a larger data set. It's composed of around 1,103 patients, reflecting real-world data. And they look into the efficacy and safety of the fixed-dose combination of the 275 naproxen and 325 paracetamol. So they would enroll patients seen in the ambulatory clinic, and they would look into the outcome measure, the pain scores by the visual analog scale, as well as the face type of pain scale. So they want to reflect the real-world data. So they're able to demonstrate that your combination naproxen paracetamol significantly reduced pain after 5 to 11 days compared to baseline. And the median pain score would be 3 at baseline, day 0, and it would reduce to 0 at days 5 to 11. So the difference is clinically significant. At baseline, at least 300 or 36% has VAS rating of 3, and after treatment, it's around 1%. And more than half of the participants, 56%, had no pain after treatment. No safety signals for this duration of the study. So they look into the 2 types of pain scale. They look into the face assessment, the VAS score for face assessment, and they also look into the VAS score for pain intensity, the numerical pain scale. So to summarize, when we talk of this combination of naproxen and paracetamol, they were able to claim the better pain control based on 2 clinical human studies, the POC small study, as well as the real-world data that they presented. And they would demonstrate that their lower dose, the 275, shows an increased inhibition of your inflammatory markers, your ionos 2, your cyclooxygenase 2, and it is comparable, if not better, anti-inflammatory effect versus the higher dose naproxen and the current available 375 that's available outside. So no safety signals, and the fixed dose combination would provide a better safety profile. So basically, when we look into the in vitro, when you take into account the in vitro, in vivo, and this current two human studies that they have conducted, at the moment, when we're doing the module development, there are still several human studies ongoing. They're looking into the geriatric study, and it's projected to be completed in 2 years' time, as well as this continuation of the VOC study. So a lot are still ongoing, and the articles are still in press.
He did it in 20 minutes.
So in summary, the use of combination analgesics with multiple and complementary mechanism of action is well-founded in pharmacological science, and this time they have a local R&D. The pain can be multi-mechanistic, and the combination analgesia with agents having different MOA would better address particularly rheumatic disease states that would require an anti-inflammatory activity as compared to the current available analgesic combination that we have. And the combination of the paracetamol and naproxen show that they offer greater analgesic benefits without much safety profile. Thank you very much.
Right pedal.
Right pedal.
Insert. Dito po.
Right pedal muna. Okay, sir.
Change pedal. Then pull. Very good. One more.
Balik ako sa right.
No, yes, no po.
No. So alternate na yan.
Yes po.
Okay. Yan.
Insert. Change.
Teka. Okay.
Change pedal, then pull. Very good. Thank you, sir. Dito po. Saan? Dito yan. Hindi ma'am, dyan po sa gitna po.
Sa gitna. Okay.
Change pedal, then pull. Very good. One more.
Change pedal.
Stay to the left, ma'am. Ialis niyo po yung right. Ialis niyo po ito, ma'am, yung right. Stay to the left, ma'am. Ialis niyo po yung right. Yan, ma'am. Insert. Change pedal, then pull. Very good. Thank you, ma'am. Ayan, ma'am.
Okay, rolling.
Baka masira to mo.
Well, everybody, would you focus your mind? Search for the truth and you'll find. Good spirit and strength from within.